5, 4, 3, 2, 1. Let's go. Diary of a Kidney Warrior. Sharing faith, knowledge, hope, and love.
Hi and welcome to Diary of a Kidney Warrior podcast. My name is Dee Moore and I am a stage 4 kidney warrior. This podcast is dedicated to encourage, educate and inspire as we explore all aspects of kidney disease, chronic illnesses and health. If you have any questions or ideas for topics you would like me to cover, please get in contact with me on social media using the handle Diary of a Kidney Warrior. Today's episode is the premiere of the listener-led episodes. These are episodes where the questions are chosen by you. Joining me today to answer your kidney transplant questions is Dr Frank Dor. He is a consultant transplant surgeon and clinical lead of transplantation at Imperial College Renal and Transplant Centre based at Hammersmith Hospital. He is passionate about all aspects of organ donation and transplantation, connecting with and involving patients, education, science, and excellent patient care. He has a special interest in living donation and preemptive transplantation, and is a council member of ESOT and BTS, chair of the Clinical Ethics Committee at Imperial College Healthcare NHS Trust, deputy chair of the NHS BT Kidney Advisory Group, and involved as editor of several scientific journals. He has a special interest in social media and set up the ESOT Social Ambassador Programme and ESOT Chat. Hi and welcome to Diary of a Kidney Warrior, the podcast. How are you doing today, Dr. Dor?
Great, thank you. And you, Dee?
I'm feeling really good. I'm very excited about this interview today. And this interview is very different to other interviews that I've done in the past because the majority of the questions have actually come from the podcast listeners. So I'm very excited to hear your answers to the question and to get interactive.
Sounds good to me. I'm also very happy that most of the questions came from patients.
Excellent. So the first question before we go into those questions is, how long have you been a surgeon?
Well, actually, I was looking up the data. I qualified in 2001, and since then I've been in training for a surgeon and been a consultant for more than, I think, 12 years.
Okay. And how many surgeries have you done?
Well, also there's this very difficult question actually, but it's really thousands and thousands. I did 2,500 surgeries during my training, and
Wow.
I think that has multiplied by many numbers after that.
That's a lot of surgeries.
Yeah, absolutely.
And what was your very first surgery?
Well, obviously you have the little things to remove in outpatient clinics, but I haven't counted those. So my first real operation under a general anesthetic, a patient under a general anesthetic, of course, was an incisional hernia repair. So it was basically a hernia because of an operation that the patient had before. And it was quite a big operation. It took about 2 hours, and it was after a big abdominal operation. But it went very well. I was really excited.
And 2,000 plus surgeries later, here we are today. It really is a pleasure to interview today. So the first question coming from Jerome on Instagram, his first question is, how will I be evaluated for a transplant?
Yeah, this is a great question, of course. So evaluation for a kidney transplant, because that's what we're talking about, assuming, involves quite a lot of blood tests. And obviously, as a kidney patient, you will have had many blood tests in your career, so to speak, as a patient. But we do a very extensive set of blood tests, including kidney function, liver function, various viruses that people might have had. So as broad as possible. Obviously, you need lots of scans, so imaging, as we call it. Quite often, people will have an ultrasound of their kidneys, an ultrasound of their whole abdomen, and also many patients will have had a CT scan to look at the blood vessels where a kidney transplant should be positioned, if those blood vessels are of sufficient quality, because they could be attacked and damaged by a process called atherosclerosis. And that's unfortunately the case in many people who have kidney disease, for example, due to diabetes or high blood pressure. So that's really an important investigation. On top of that, there's several colleagues who we ask for an opinion. So lots of people will see a cardiologist, and some cardiology testing might be necessary. Obviously, a chest X-ray to look at the heart and the lungs, an EKG, and often people need some sort of functional testing of the heart. So is the heart capable of supporting a person safely during an operation, and especially for a transplant, to assess any risk of the coronary arteries, so the arteries that supply the heart with oxygen, that could also be damaged by the kidney disease or the underlying factors that have caused the kidney disease. And then we often ask an anesthetist to give an opinion, because many people will have other problems of their health that could affect their suitability for a big operation. And of course, if there's any other issues that were found or identified in the overall medical history of a patient, we ask another expert to look into that according to their specialty.
Wow, that's a very in-depth process. There's a lot that you have to take into consideration. It's more than the kidneys themselves and the vessels around that. It's everything, isn't it?
Absolutely. And of course, part of this evaluation for being a kidney transplant recipient, we ask our tissue typists, so the specialist on tissue types, to look at the patient's tissue type and blood group. This is important because a potential donor obviously would need to be as good as possible matched for the tissue type, which is called HLA. This is the human leukocyte antigen, and basically that's quite unique for every person. And we want a donor organ to be matched as closely as possible to the recipient of that organ. So that will have to be taken into account before you can be waitlisted for a kidney transplant or being considered for a live donor kidney transplant.
The next question is, what's the process to find a match? What can or should I do to improve my chances of being matched and get off the waiting list sooner?
Yeah, I would like to take one step back, actually, because the question is really, how can I be most successful in getting a transplant? And I think this is a crucial point. And unfortunately, the default is that many kidney patients and their doctors expect a patient to become a dialysis patient first before they are even considered sometimes for a kidney transplant. And in my opinion, this is not the best approach. So I think what we could do here today is also empower people with the knowledge that should you reach a stage of your kidney disease that would require dialysis in the future, I think before we start thinking about dialysis, we need to consider a so-called preemptive transplant. So this is a kidney transplant before we actually have dialysis on board for the patient. So that requires, of course, a very early education of people. And that's why I'm so excited about this podcast, because this is part of educational processes for patients. So if you really reach a stage of your kidney disease, say that your kidney function is about 25-30%, it would be time for the advanced kidney care nurses or the advanced kidney care team, otherwise known as low clearance team, or even pre-dialysis clinic. And obviously that's not a term I particularly like and support. But it would be time for those professionals then to educate patients that a preemptive transplantation would be the best option. And obviously, kidneys are not just out there on the shelves in the hospital.
No.
And therefore, we need to really make sure that people know that the best possible chance for a kidney transplant will be through a living donor. So anyone who can find a living donor in their social network, because you don't have to be family or blood related, it could be anyone who is willing to donate a kidney out of free will and obviously without payment, they can be considered, and then that process takes some time. And obviously, this is not just something that people can accept really easily, because first you have to accept you have kidney disease that is progressive, and you might need renal replacement therapy in the future, which is really, really a difficult thing for people to digest. And I say this without being a kidney patient, but having seen really, really thousands of kidney patients in my career that were all struggling. No one said, oh, that was super easy. Yeah, I accepted it, and I just talked to some friends and family, and all of them wanted to donate. This is a process. So the earlier patients have told me the education is, the better. And I wholeheartedly support that, because it buys you time, it buys you options. And I think, especially if you are in a situation where you feel that hope is almost lost, I think we need to provide people with options and opportunities to go out and talk about your kidney disease, to share with your loved ones that a transplant is the best option, and that living donor kidney transplant is the best option, and even more so if we can prevent dialysis at all. But unfortunately, the system is not set as such in many kidney units in the UK, but also the rest of the world. In my native country, my home country, the Netherlands, that's a little bit better in that respect, I must say, where people really have left the default that dialysis always precedes transplantation, and that living donation is the best option. And there are lots of barriers, of course, that people will face. It's difficult. You're not just asking someone, can I borrow a cup of sugar? It is a real big thing. But on the other hand, for loved ones, it's also very difficult to see that their loved one is getting worse from their kidney disease, and that they are condemned in a certain way for a very difficult life with a chronic illness. And if you look, and this is my big driving force, if you look at the patient survival rate, so your chance to live healthily and well without dying on dialysis is much worse than the quality of life and the length of life that most transplant patients will have. So a kidney transplant should normally buy you at least 10 to 15 years of life in good quality. And this is, I think, very important to realize. And lots of people don't realize that, for example, the prospect of life, so basically how long would you live likely on dialysis, is worse than many types of cancer these days. So this is an eye-opener for many people, and they never heard about that. And of course, I'm not trying to to pick the very rosy picture for people, but this is evidence-based and real. So there's a big incentive to do early education about preemptive kidney transplantation with a living donor. Also, of course, preemptive transplantation with a deceased donor would be great, but we simply don't have enough of these organs available. And the quality of a living donor kidney is generally much better than that of a deceased donor kidney. This makes sense because a deceased person just died, and they didn't die because they were so healthy. The number of road traffic accidents in young people, like in the past, that would come to an organ donation is really limited. So most patients who donate their organs have been very ill for at least some time, and these organs will definitely be of less quality than most of the living donor organs, because that's a well-selected person, has had many medical tests, and would generally be of great health actually when they go into the donation, because otherwise they wouldn't be able to survive on one kidney for the rest of their lives, which is a normal length of life for living donors. So it all comes together beautifully by saying preemptive live donor kidney transplantation should really be the default. Early education to achieve that is hugely necessary, and also would provide people with time, so buying time to investigate the options. And of course, if nothing else is available and all the options seem not suitable, then obviously the life-supporting dialysis treatments with either peritoneal or hemodialysis are still very good options for people as a temporary solution to transplantation.
Wow, there's a lot there to consider. I mean, I myself am stage 4, and there was a discussion a while ago about preemptive transplantation, but there's been no discussion since. So it's very interesting that you believe in that, as that should be the standard. And I hope that a lot more surgeons and nephrologists will look at that across the UK and across the world.
I hope so too. And there's really good evidence in the literature that the outcomes of preemptive transplantation are much better. And also many people will have, so some people say, oh, you should have a period of dialysis to know actually what it feels like to be on dialysis, and then you start appreciating your transplant better. So that's almost like a punitive measure. Some people say, well, people take their drugs really poorly after transplantation, and certainly if they haven't been a dialysis patient, then they won't appreciate how important it is to take these drugs. All these things are definitely not true, and simply reflect an old-fashioned assumption and an old-fashioned system.
I think it's also making the assumption that because you haven't gone through something that you can't appreciate how serious it is as well. Saying that, oh, if you haven't gone through that, then you're not going to take it seriously. I think that's very negative. From when you have the diagnosis of having kidney disease, you already know that you're in a serious situation. And so, I mean, speaking personally, I can't speak for everyone, but you're going to want to do all that you can do to help yourself. So I think when you're given that lifeline, people are going to embrace that and say, yeah, I'll do whatever it takes. So I definitely think that that's a negative thing to make that assumption.
Yeah, and I understand that completely. And also what I understand is, and I hear this from lots of kidney patients, they are reluctant to talk about their kidney disease and their need for a transplant, even though it might be, far away in the future. People might also feel reluctant to ask, or even feel that they ask or force in some way their loved ones to make a decision to get tested to be a potential live donor. That is something I would also completely understand, but I also hear the other side of the story in our patient seminars and educational sessions. I get a lot of questions from relatives and friends of people that refuse to take their offer to be a live kidney donor for them, just because they don't want to put their own health above the health of someone else, and they feel that they might jeopardize the health of that particular potential live donor. But obviously, I can only reassure everyone that only those people who we tested extensively, only those people that are deemed healthy enough to live with one kidney and healthy enough to live through that operation safely and can look after themselves well, will be allowed, so to speak, to donate their kidney while they're alive. Because, of course, we are not here to make two patients out of the situation by having a live kidney donor into trouble. That's never an option.
That makes sense, because one of the questions by Kristen is, for a donor, how does the kidney function change after donating a kidney? Everyone says no change, but there has to be. At the least, it takes longer for the body to filter and produce urine.
Yeah, that's a great point. And this is, of course, the The cornerstone of living donation is that we determine as to whether a person is able to live with one kidney healthily. So if you remove one kidney during a live kidney donor operation, this is called a live donor nephrectomy, we remove the kidney, and then the next day, it's very interesting, because if you assume that two kidneys provide 100% of kidney function, if we take out one kidney, you would expect that 50% of the kidney function is left, more or less, correct?
Yes.
But actually, it is always much higher. So the remaining kidney picks up their reserve capacity immediately as soon as the body understands and feels that they only have one kidney left. That particular kidney would go in a bit of overdrive. And so the kidney function, if you look at GFR, for example, and assuming the GFR is, say, 90 in the donor, the next day, it is very likely for this GFR to be around 60 of the 90, rather than 45.
Okay.
And the creatinine, you never see a creatinine going up twice as high unless there is another problem, but this is extremely rare. Like a patient, a donor might not have had enough fluids or things like that. But in general, the kidney function picks up very quickly after removal of a donor kidney, in a living donor, that is. And in the first year, you see that the kidney function then slowly starts to increase, and at some point it reaches a level which is sort of the new GFR or the new creatinine for the donors. And that could be that it is not completely normal, because it will never be the same as it was with two kidneys, but it is something that we would like to see as stable. And we follow up our living donors on a yearly basis, a bit more in the first year to see how things go, but in the rest of their lives as well, every year. And what people should also realize is that any living donor in the UK, but also in the Netherlands and a few other countries, that would develop a kidney problem, say, in 3 decades later, because there was a small renal cell cancer in the remaining kidney, just unrelated to the donation. But that person would only have one kidney left, and that would need removal of that kidney, and thus it would need they would need a transplant or dialysis temporarily. Those people will get prioritized for a kidney transplant in these countries that I mentioned, so that there is a lifelong safety net, basically, for any person who donates a kidney while alive.
I didn't know that.
There you go. But that's why we're here, right? To discuss these things and to make sure that other people know as well.
Absolutely.
By coming to these yearly visits, it's like an MOT of a living kidney donor. You can sometimes identify that in case a person develops high blood pressure. These things quite often, as many patients will know that listen to this podcast, you live with hypertension with high blood pressure sometimes for years without realizing that you have it, and then you come with kidney problems due to the high blood pressure. So by looking after our donors, we can see at least that if someone develops high blood pressure, we can treat early. And this is true for other health problems as well. So it's a great way of preventing problems and treating them immediately when they arise.
The next question, back to Jerome, is what will my recovery be like? How soon will I be able to go home? And how often will I need to come back for checkups? Yeah,
another very good point. And I know that healthcare is moving. So we are looking much more in patient-reported outcome measures these days, rather than what is important for the doctors or the team. So this is a great question and relates to PROMs, patient-related outcome measures. Of course, any operation has a certain time of recovery, and in general, every operation somehow seems to have that. It's about 6 weeks of general recovery. So the day before the surgery, you get admitted to the hospital, then you have your operation. In case this is a planned live donor transplant, then at least 1 day in advance, of course, that you can come into the hospital. And the hospital stay depends a little bit on how well the kidney starts picking up. So with live donors, those kidneys start to work immediately in 95 to 100% of the kidneys. With deceased donor transplants, so these kidneys often have a bit more a troublesome road to the transplant in terms of they come from a person who just died, they have been on the road for several hours because it often is not from the same city as where the recipient is. And then the recovery is also a bit longer. So those kidneys sometimes are sleeping, as we call them. Official term is delayed graft function. So these patients quite often need a bit of dialysis for a couple of days or even a week. But on average, a kidney transplant recipient from a live donor stays about 5 to 8 days, if all goes well. And for a deceased donor kidney transplant, this is more like a week to sometimes 2 weeks. And of course, if there's complications, there's always a chance that it will be longer, but these are the averages. And then the general recovery, depends how fit you were before the transplant. And again, if you have not been on dialysis for 10 years, for example, you are a bit fitter going into the operation. And depending on your age and your body mass index and other health problems you might have, this will also impact on your total recovery. So the fitter you are, and that's why I always like to see videos from yourself, for example, working out, doing the best you can to stay fit, eating healthily, trying to sleep regularly, and having as normal life as potentially possible, because I realize that it's not easy for kidney patients, and especially I talk to lots of dialysis patients on hemodialysis. I mean, life is not easy, and it's very easy to say from a doctor's perspective, go and do some exercise. But if you're on hemodialysis for 3 times a week and you're bummed out before and you're bummed out after, and you nearly don't have normal days where you feel completely fine, I think it's very difficult for us, for patients to do some exercise and do extra things. But if you are fitter, obviously going into the operation, you obviously also need less time to recover. But many patients mention right after the transplant, if the kidney is working straight away, they mention that they feel like a new engine is burning, and the new engine is giving them lots of power and the will to recover. And most kidney patients, when they are transplanted, are quite often cold and itchy, and the skin color is not healthy. And immediately after transplantation, they start feeling normal in most cases. So it's really magic to see that happening. And for people that haven't been going to the toilet to pass urine, all of a sudden become very emotional for something that people don't even think about. You go to the toilet and you pass urine, and that's a normal thing to do. But some people really become emotional after all that. So it's magic, and it's really beautiful.
George is on Instagram, is asking, what's the biggest change from the first transplant you did compared to now?
So, well, obviously there's a couple of thousand transplants under the belt. So I feel in the first kidney transplant I did was obviously with a very senior consultant surgeon assisting me and showing me the way. And every step of that operation, you find your way, and it's difficult. Now I dare to say I have seen all the potential difficulties that could arise with any step of the operation. I've had complications, I had to solve complications, I had to solve life-threatening issues. And there will be people listening even in, because I have been in contact with quite a number of patients that I have been operating on, with either smooth rides, but also sometimes really difficult rides, so to speak, with difficult and complicated surgeries. So the biggest difference for me is I don't take things for granted, but it's really the experience. Technically, not many things have changed in the operation, and the principles are all the same. I do think that in general, patients that we transplant are, we don't have any more limits in terms of how old you could be, as long as you're fit enough. And also, I'm very keen to take on very complex cases, because I think the chance of a transplant changing a person's life for the better is always greater than not to transplant. So you become really inventive as to how you could overcome problems or even prevent them, even when there's really complex cases and complexities that might jeopardize the outcome. So experience is really the difference, but all the rest has remained the same. The drugs, there's not much change in the drugs for the immunosuppression, the drugs you should take to prevent the kidney from being rejected by your own body. Those drugs haven't really changed over the last decades. And the whole approach, the only real difference is that we have come to the understanding that being in a hospital doesn't mean a patient should be in his or her bed for all that time. And we nowadays really know that outcomes of any operation, but also for transplant operations, are better if the patient gets an enhanced recovery pathway. So that's relevant to the previous question as well about the recovery time. A kidney patient or a living donor, anyone I operate on, gets dragged out of their beds almost immediately. And you're not starved anymore in the hospital. You can eat almost immediately. And we really, really start encouraging people and stand there on the sideline and being the biggest supporters of, come on, you can do this, and you can get out of bed and you can take that step. And it provides all the systems from being reactivated from scratch. And that's so much better. And that's so much better for people's mental health as well. So that's another big change, that it's no longer like you have to stay flat in your bed for 7 days. We moved away completely from, let's get rid of those beds and let's sit you up, let's sit you out, let's walk around, and let's be active.
That's a really good change.
It's good, huh? And it works, it really works.
George's next question is, what's the toughest part of the job?
The unpredictability of the cases. So if you're on call as a transplant surgeon, obviously there's a small chance that you're not transplanting, but being on call normally means you have a normal working day and a normal working week. And on top of that, you're on call and you might have to do a transplant or sometimes multiple transplants in the evening and the night throughout. So you have worked your whole day and then you start being on call and doing your transplants. And then the next day, quite often you're still working somehow. Of course, we are cross-covering each other, so that if I've been doing 2 or 3 kidney transplants in an evening and a night, the next morning I was going to do another operation. We try, of course, to make sure that people get their cross-cover or plan the on-calls in such a way that this doesn't happen frequently. That's tough. Also, this is not to be dramatic, but it's a big responsibility to deal with the gift of life.
Yes.
I see that completely, because it's a person's wish to help other people in need of a transplant by donating their organs, either alive, as a live donor, or as a deceased donor. It's that precious organ that so many people have waited for years, or in desperate situations, that we basically don't allow ourselves complications. We are quite tough on ourselves, and we know there is some limitations in what we can do, but overall, I think there's always pressure to do well. And of course, when time flies by, with experience, you become less nervous about it. But still, your transplant that you're doing that day might fail on the table because of something you do or something that happens during the operation without you doing that, and sometimes completely unrelated to you. But something might happen that would jeopardize the outcome of that transplant, and the transplant might fail. And that's still our responsibility. No one else's. It's not the nephrologist's responsibility. It's not the anesthetist's responsibility if something goes wrong. Ultimately, it's my responsibility. So that's quite. Sometimes it is really difficult, and luckily, I'm quite resilient and I'm quite good with dealing with stress. But I see this is a burden on many people. So the resources are stretched. We often have to wait for several hours. People don't realize that, but I sit in the coffee room in the theaters in the middle of the night, quite often waiting until my patient is there for me to operate on. You have to wait because there's another emergency that would kick back your starting time. And then without too much sleep, it could be difficult for many people to deal with that. And often, of course, when things go well, and thank goodness, most of the times things go really well, and we can celebrate every transplant for people and the impact it has on their lives. But if things go wrong, it is really, really wrong. And it has a big impact on the patient, but also on the surgeon and the rest of the team, obviously. So those are just some examples. But overall, it's a hugely rewarding job. It's great because I know many people that I operate on because I've seen them in the transplant assessment clinics. I sometimes have operated them for a peritoneal dialysis catheter or a fistula, sometimes have removed their polycystic kidneys pre-transplant, and you have a longer relationship than just that particular moment, and you see them back in the clinic as well. So that's another reward for us to see that really it impacts so positively on so many patients.
That must feel so good to know that what you're doing is literally changing people's lives for the better.
Yeah, absolutely. But if things go wrong, as I said, they really go wrong, and then it's still my passion to be there for the patient and their family, and to stay in touch where some special relationship has built.
George's next question is, what is your most memorable transplant?
Yeah, there's not just one, but I can give you one example. In my previous life, I often refer to that as my previous life when I was a transplant surgeon in Rotterdam, in the Netherlands, in the Erasmus MC. I also was a liver transplant surgeon. I don't practice liver transplant surgery at the moment because we're not doing liver transplants at Imperial, where I work. But my farewell operation is probably one that I will remember for a long time. That was more than 5 years ago now. It was my very last on-call. And we were doing mutual aid for another transplant center that was temporarily closed due to some logistics. And we had a very high urgency liver transplant recipient on the waiting list for them. And that patient got an offer for a very good liver, and it was very complex. It was the third liver transplant. There were drains sticking out, the sick liver that had to be removed. Very, very complex surgery. It took 27 hours. He had 46 liters of blood loss.
Wow.
Of course, with a machine that would auto transfuse that blood that we lost. The liver, that was also remarkable because it was a very good liver, but if you keep a liver for such a long time outside a human body, it won't survive a very long time. And we, for the first time, could employ a special machine that would keep the liver preserved under special conditions by putting it on a pump, basically. And that was the very first time we did it. And actually, because probably we did that, the transplant, after removal of the sick kidney, the sick liver, that was the biggest difficulty of the whole operation. we could manage to have the patient was home within 2 weeks, which is remarkable for a liver transplant, and still doing really, really well. And, that was very memorable because it was one of the most tough on-calls I've ever done. But there's several, and of course you remember transplants that had not so good outcome, or where we just escaped that a person died during a transplant. And with liver transplant, that happened regularly, actually, that you really had sick patients during the operation that would have a cardiac arrest during the transplant, and you had to grab the heart in your hand and really massage the heart while you were doing complex other stuff. So yeah, it is impactful, and I remember a lot of operations actually still, and especially the patients attached to those operations.
Wow, that sounds absolutely incredible. The next question on my list is by Mike from Twitter, but we've actually covered his question because he was asking about preemptive transplantation, and he was also asking about the process of transplantation. So just acknowledging, Mike, that we have seen your question, but it's also been covered. So
Indeed.
the next... Sorry.
If I may,
Yes.
we haven't said yet, because we were talking about living donors and their evaluation and things like that.
Okay.
And since Mike's question was already covered, it's really good to know that living donation brings so many other advantages over deceased donor transplants, because you can plan the operation. You can so it's not just a great kidney coming from a very healthy person. You can plan the operation, and therefore you can do very difficult things. And even those patients who have a living donor option that is not matched, to come back to the matching question, if your blood group is different, it could be that you can't have the kidney that the living donor that wishes to donate to you, but you might be able to, and we have a system for that obviously in the UK. It's called the UK Living Donor Shared Scheme, otherwise known as paired and pooled transplantation, that we find other pairs in the UK that are in the exact same situation as you are. They have a living donor, but they can't have the kidney from that particular donor themselves. And you can just swap kidneys from these donors, of course, anonymously organized by NHS Blood and Transplant. And that would enrich your opportunities for transplant enormously. And other people will benefit from that same living donor option as well, because otherwise they wouldn't have had the opportunity to be transplanted. And quite often these paired transplants are initiated by complete anonymous people that donate their kidneys in an altruistic way, or as quite a lot of people actually that do that don't find it really altruistic. They find it a completely normal and right thing to do. But they can start a whole chain of transplants. And in the end, someone from the waiting list gets called up for a living donor transplant, because they're end of the chain. Someone has to receive that last donor's kidney, and they also benefit. So that's one thing I wanted to highlight, that people have, especially women that have been pregnant, they can have antibodies against a variety of tissue types from potential donors, and might not be transplantable from a deceased donor transplant easily, because it's very rare to find such a matched donor for you. And we'll get back to that hopefully later. But that's another very good advantage of the living donor transplant. Also, some people need pre-treatment before they can be transplanted, to remove certain antibodies or circulating factors from the blood, or to start some immunosuppression beforehand because of their primary kidney disease, so the underlying problem. That's something you can only do with living donor kidney transplant, because you know when you're going to do the transplant. So those are additional advantages of living donor kidney transplantation.
Jonathan on Twitter asks, what do you think of the future of kidney dialysis stroke transplant will look like? Bionic or mechanical kidney?
Yeah, great question. I wish I would know, because then I would know where to invest in professionally and also perhaps personally. I do think technology is moving ahead. We see some initiatives of really small implantable dialysis or even implantable kidneys, people call it, with highly advanced technology, replacing the good old dialysis machines. There's people who I think that those are progressing, but not to the speed that people have expected them to progress at. And I don't know why that really is, but I think it's very different. People come to the realization the kidney is not so easy to replace, and even the dialysis machine, of course, is not the same as a kidney because it can't replace all its functions. And dialysis patients that are listening know that all too well. You need several drugs to compensate for all the things the dialysis machine can't do. So I don't know where this is going to head. I'm sure there will be implantable or mini dialysis machines that you can carry. I think the biggest revolution is now that lots of people get access to home hemodialysis, which is of course much better for many people than in-center hemodialysis. Whether I would put my money, so to speak, on the development of 3D printed constructs that could be kidney seeded with stem cells that would form a new kidney. You see publications every year, and this happens in my whole career already, where you see that, kidney in a dish is already developed and it's ready for patients in a year. I find this really difficult because science is fantastic, but it simply doesn't work so quickly, and it needs lots of time and it needs further developments, and you see that with everything. So I think the future might be that I might be implanting kidneys in the future that were from a 3D printed background and constructed with stem cells, and perhaps people invent even more smart ways. So you could also, for example, have a porcine, a pig kidney that is then decellularized. So all the living particles are basically removed by various processes. And again, human stem cells are brought into that to seed and rebuild the kidney. So it might be either of those options that would form the future. I don't know. It will be very fascinating to keep following. But for now, there's nothing better than a kidney transplant for patients.
The next question comes from Helen on Twitter, and she says, I've been waiting 4 years for a kidney. I'm told I'm a complex case due to antibodies. I'm losing hope. What are my chances? I don't understand.
Yeah, this is a great point. And unfortunately, this is a reality for many patients waiting for a kidney transplant. So Helen, you're not alone. The complexity of antibodies is that they're quite aggressive. So as soon as the antibodies are antibodies against someone else's tissue type, I was alluding to that earlier. So if you have antibodies against the majority of tissue types of donors from the last 10,000 donors that came by in the UK, we can test that, and we test for that. And this is called your CRF, your calculated reaction fraction. So if you have 100% antibodies against all these 10,000 past organ donors in the UK, you can calculate your chance to get a match, which is very close to zero. It might not be zero. So there are several things there. First of all, again, it would be important to, I don't know, Helen, I think, so it would be important to investigate as to whether all the living donor options were explored. is there someone willing to donate? Even if their tissue type is not the correct one, we can come back to the paired and pooled transplant scheme. Somewhere in the UK, there might be a living donor that, has that rare opportunity for Helen to be a match. And by having a living donor, even if it doesn't reflect a match for yourself, it could be that opens up a new pool of potential donors. And by swapping these kidneys, of course, you could still get transplanted. That's one thing. Then, of course, there are some centers in the UK and in the world, although it's become a bit more rare than in the past before we had the sharing scheme. You can remove antibodies and do pre-treatments of patients with quite aggressive therapy with immunosuppression, with several other drugs that people don't normally get. So with special dialysis, it's called plasmapheresis or plasma exchange. You can remove perhaps these antibodies successfully. And again, you would need a living donor to plan this treatment, because you can perhaps remove them with the treatment. But if you then don't have a kidney offer, that you could then not get transplanted because there's simply no kidney available. And these treatments normally don't last forever. So you might just have a window of a couple of days to a week when the antibodies have been removed and they stay away, for them to do the transplant and again come back with your immunosuppression in more aggressive ways than you would normally have immunosuppression. That might be an option. But that only really works with living donor kidney transplantation. And of course, those results are not as good as if someone doesn't have antibodies that need to be removed. So we have to place that in context. But those transplant outcomes could still be much better than the survival on dialysis. And the longer you have dialyzed, the more problems you could expect. Of course, some people stay on dialysis for years and years and years without too much problems. But most dialysis patients in the end will develop some problems. So that's one thing. Then we have changed the way that deceased donor kidneys are allocated. So even though there's not a kidney just available on the shelf for everyone, you still need to do that. You still need to allocate any kidney that becomes available fairly and distribute them to those patients who, at that moment should receive that kidney in the most fair way. So NHS Blood and Transplant is doing that. Since September 2019, there is a new system, and people that have, I said antibodies with 100% CRF, for example, anyone higher than 85% is called highly sensitized, and normally very difficult to find a suitable match kidney for. Those patients are in the highest priority for that kidney to be allocated to them. If that rare tissue type that people don't have antibodies against becomes available, it would be for them. Equally, everyone who is waiting for longer than 7 years has priority over other patients in the allocation scheme. So basically, in summary, the most difficult to match patients, or the people that have waited the longest, will always get some priority in the new allocation scheme. And that we have seen at Imperial a drastic change in the first year. Of course, we had some issues with COVID that really impacted on the transplant programs. But we have transplanted lots of people that have been waiting for a long time and were very, very difficult and even impossible to match. And we were able to transplant them because of the new allocation scheme. So that is good news, potentially gives at least some hope for those people who know they are very complex because of antibodies. So there's still some options, and even though it might look completely impossible to get a transplant, there might be still sparks of hope. And of course, I don't know Helen's particular situation, but these are, generally speaking, some options that might not have been explored altogether.
So there is hope there. So hopefully that is good news.
Yeah, I hope so. Of course, I'm not promising anything, but these are things to at least explore and address with their kidney team.
And the final question comes from Truth Speaker on Twitter. And their question is, what are the guidelines regarding the use of face masks for kidney transplant recipients? And that, in brackets, it says, in general scenario, not due to COVID.
This is really nice, because it reminds me of a very nice story that we nowadays, in the COVID times, we're so used to wearing face masks. And especially, I think, kidney patients and transplant patients will vigorously do that. But people might not know that the first successful human kidney transplant was done in 1954 in just before Christmas in Boston in the US. This was between identical twin brothers, the Herrick twins, and they have that transplant went very well. And then the recipient went home, but actually, was not prepared at all to go home, and thought, why don't I go to the bank and get some money? Because I need to buy some groceries, I need to buy some stuff, because I haven't been home for weeks. The patient also received immunosuppression, and there was not an awful lot of experience with these medications. And they knew, of course, they were weakening the immune system. So they advised the patient to wear a face mask, wherever he went. And of course, this was not a medical face mask as we know now, but it was really a face mask that you see in certain Western movies, for example. So you can imagine what happened. He went into the bank wearing his face mask, and immediately the police was called, he was arrested, and people thought he was going to rob the bank. This is a story that just shows how well we have adopted to the current circumstances, and we're now all wearing face masks, so bank robbers and not bank robbers. But in all seriousness, in general, pre-COVID, people were not advised to wear face masks. Perhaps they should have been advised to wear face masks in retrospect, but at least there was no real indication that was needed. This is different to some patients who get a bone marrow transplant, and this is perhaps why the question arose. They have to be in quarantine in certain types of bone marrow transplantation, where really your whole bone marrow gets depleted, so wiped out in proper English. And therefore your immune system is so weak that you would pick up any infection that would come to you. With kidney transplant and liver transplant and other solid organ transplants, the immune system is not that weak with immunosuppression that you would pick up anything. And therefore, we normally did not advise anyone to wear face masks. But now, with COVID, definitely wherever you go, wear a face mask. If you are a transplant patient, but also if you're a dialysis patient, you're still in a vulnerable category of patients.
Thank you so much for answering all of our questions today. I've learned so much, and I know that the listeners have learned a lot too. This is the first interview with yourself, and we're hoping that you can come back and answer some more questions for the listeners in the future. So now that the listeners have heard this interview, it might spark some more discussions and might think, oh, I'd like to ask this question or that question. So we'll give the listeners another opportunity to ask their questions and invite you to come back and answer some more.
Yeah, I would be delighted, because, if you feel that there's still so many questions that you always forget to ask your doctor or your nurse, and the questions you might not dare to ask. You can even do it anonymously, right, Dee? You don't
Absolutely.
have to be named. And I'm so happy to do that. And especially with the inspirational Dee behind the microphone, it would be really nice to come back.
Oh, thank you.
Thank you for all you're doing for your fellow kidney patients.
Thank you for listening to Diary of a Kidney Warrior podcast. And don't forget that you can contact me on social media using the handle Diary of a Kidney Warrior. Please do subscribe to the podcast, and please do tell a friend. New episodes of this podcast are released every Monday. Until next time, take care and choose to live.
Diary of a Kidney Warrior, sharing faith, knowledge, hope, and love.